Hello everyone, welcome to my psychiatry lecture. My name is Dr. Lin. Today we are going to talk about depression. So first of all, I would like to start with the major depressive disorder with the diagnosis criteria from DSM-5. To diagnose major depressive disorder, the patient must have 5 out of their 9 symptoms, in which at least one of their symptoms, which is either depressed mood or loss of interest or pleasure, should be one out of the 5 symptoms. So what are the 9 symptoms? We can use the mnemonic MCCAPS can be used to remember the criteria for major depressive disorder. So which are number 1, mood, depressed mood, and sleep disturbance, and interest, loss of interest, and G4, guilt or feeling of worthlessness, and energy, like feeling the patient may have feeling of fatigue and inability to concentrate, and appetite changes like loss of appetite, and psychomotor slowing, and suicidal ideation or suicide attempt. And the duration to diagnose a major depressive disorder is 2 weeks. And additionally, the patient should have the clinically significant distress or socioeconomic or functional impairment because of this major depressive symptoms. And the symptoms should not be attributable to either substance abuse or another medical underlying conditions. And it cannot be explained by psychotic spectrum disorder such as schizoaffective disorder, and the patient must not have either manic or hypomanic episode. If the patient has either manic or hypomanic episode, then bipolar 1 or bipolar 2 disorder will be diagnosed instead of the depressive disorder. Then we can differentiate the severity into mild, moderate, and severe. So mild is like the patient is having the symptoms but not major impairment in social or occupational functioning, just minor impairment, and severe would result in seriously distressing and unmanageable and even suicidal ideation and suicidal attempt. And moderate is in between the two. Now that we moved to another depressive disorder, which is persistent depressive disorder, aka dysthymia. So this is the diagnostic criteria from DSM-5. And the duration for dysthymia is the patient should have their symptoms at least 2 out of the following 6 for at least 2 years. But in children and adolescents, the mood can be irritable instead of being depressed, and the duration is at least only 1 year. And the symptoms are depressed mood plus 2 out of the following 6, which are appetite, sleep disturbance, energy, and low self-esteem, and poor concentration and feeling of hopelessness. And another thing is the patient should not have the symptom-free period for more than 2 months during this 2-year period. Okay, let's move on to cyclodynamic disorder. So for cyclodynamic disorder, the diagnostic criteria is the duration is the same as dysthymia, which is 2 years, and for children and adolescents will be 1 year, and the patient will have the symptoms of hypomania but that do not meet the criteria for hypomanic episode, and the patient will have depressive symptoms on the other time but that do not meet the criteria for major depressive disorder. So the same as a dysthymia, the patient should not have the symptom-free period for more than 2 months during the 2-year period. Okay, let's now move on. Atypical depression. So what is atypical depression? In DSM-5, which is described as major depressive disorder with atypical features. So the patient have the mood reactivity. So mood reactivity means that the patient have the capacity to be cheered up one presented with the positive events such as a visit from children or grandchildren, or when he received compliments from others, then the mood become euthymic instead of being sad. And the kind of euthymic mood can be present for a long period of time as long as the external circumstances remain favorable. And another thing is increased appetite, and as well as weight gain. And hypersomnia may include either an extended period of nighttime sleep or daytime napping, that specifically at least 10 hours of sleep per day, or at least 2 hours more than when not depressed. And another special feature is leg-dan paralysis, which is defined as the feeling of heavy or leg-dan or weighing down, usually in the arms or legs. The sensation is usually present for at least an hour a day and often lasts for many hours at a time. And the last feature is rejection sensitivity. And unlike the other atypical features, this sensitivity is early onset and persists throughout most of the adult life. So long-standing rejection sensitivity, and it may be exacerbated during the depressive episode. Okay, let's turn to another topic, which is PMDD, premenstrual dysphoric disorder. And the patients, the woman, will have at least 5 symptoms mostly present in the final week before the onset of mens, and the symptoms improve within a few days after the onset of mens and then become absent in the week after the menstruation. So for the symptoms, most of their girls may experience one of the listed symptoms, at least one in her lifetime, maybe the mild form, and the symptoms become, if very severe, so severe that it becomes pathologic, and 5 out of the following symptoms, it can become the PMDD. So the symptoms are mood swing and irritability, anger, interpersonal conflicts, and the mood instability, like depressed mood, feeling of hopelessness, and self-deprecating thoughts, and anxiety, tension, so feeling of being on edge. Additionally, the patient may have the symptoms of decreased interest in usual activities such as work or school or friends or doing hobbies, and subjective difficulty in concentration, and the lethargy and easy fatigability and lack of energy, and appetite changes and sleep disturbances, and the feeling of overwhelm or out of control, and the physical symptoms such as bloating or weight gain. And there are also other specifiers in depressive disorder. So the depression may be associated with the psychotic features. So depressive patient may have the delusion and or hallucinations, and which can be mood congruent psychotic features or either mood incongruent psychotic features. So mood congruent means that the content of the delusions and hallucinations are with their depressive themes. For example, the patient may have the belief of having committed some unforgivable crime, or like hearing voices criticizing them during the depressive episode. Conversely, the example of mood incongruent hallucinations during MDD would be like voices telling the patient positive things about themselves or that they have the superpower. And another specifier is a seasonal pattern. So previously we call it seasonal affective disorder. So it is like the patient is having the major depressive episode in the major depressive disorder, but in a particular time of the year, especially during the winter or fall. And there are also other specifiers like major depressive disorder with anxious features or mixed features or melancholic features, or with catatonia, periparent onset, etc. So I'm not going to go the detail about those specifiers. And I would like to emphasize on suicide. because suicide is the most serious consequences of a major depressive episode. So in depression, suicidal ideation and suicidal planning attempts are highly prevalent, and the risk of suicidal behavior is present at all times during depressive episode. That's why we should do suicidal risk assessment as part of the routine clinical care. Here we can see the risk factors for suicide. Some are non-modifiable and some are modifiables. Among these factors, I would like to stress about the previous suicide attempt, which is the strongest risk factor for suicide. And the other risk factors are elderly male and family history of suicide or history of legal problems or being of sexual minority and active suicidal ideation, hopelessness, and etc. Now we have discussed about the diagnostic criteria for different depressive disorders and as well as for risk factor for suicide. Now we are moving to management, how to manage depressive patients, depressive disorders. So this is their table from American Psychiatry Association Guideline from 2011. And we should note that the psychotherapy as well as the psychopharmacology, they are similarly effective in depression. So if we combine those two modalities, that patient can have more benefit. And we should add the antipsychotic medications in patients with severe depression with the psychotic features. And I would like to highlight that the psychotherapy is appropriate for both men and women and individuals of all ages, all levels of education, and all cultural and ethnic backgrounds. And the psychotherapy is effective for both mild, moderate, and severe depression. And whenever possible, psychotherapy should be offered to a patient first. And the first-line psychotherapy treatments for acute depression include the CBT, cognitive behavior therapy, interpersonal therapy, and behavior activation. And for maintenance, again, CBT and mindfulness-based cognitive therapies are effective, and they are the first line. For psychopharmacology part, we have antidepressants, and the effectiveness of antidepressant medications are comparable between the classes of antidepressant medications as well as within the class of medications. So we can choose a medication depending on the patient preference or the nature of the prior response to medication and the safety profile and the tolerability and the side effects of the medication and the concurrent psychiatric or general medical conditions, and as well as the pharmacologic properties of the medication and as well as the cost. So for most patients, the first line antidepressant medications are SSRI, SNRI, mirtazapine, or bupropion. So for SSRI, we have fluoxetine, paroxetine, citalopram, escitalopram, and sertraline. And the side effects of SSRI are sexual dysfunction, which can be anorgasmia or reduced libido, and the sexual dysfunction, sexual side effect is the most common side effect that patients are intolerable to the SSRI. And the serious complication or side effects of SSRI is serotonin syndrome, which can be lethal and very distressing. And the other side effects are SIADH and GI distress. Among the SNRI, we have venlafaxine, desvenlafaxine, and duloxetine. The side effects of SNRI are hypertension, stimulant effects, sedation, and nausea. Other atypical antipsychotics are the bupropion, which is we call it NDRI, which inhibits the norepinephrine and dopamine reuptake. So, which can also be used for smoking cessation, and their side effects are stimulant effects such as SNRI, and their significant side effects of bupropion is the seizure because it's lower the seizure threshold, especially in patients with eating disorders. But the bupropion has a favorable sexual side effect profile. Sometimes patients may prefer bupropion over SSRI because of the sexual side effect profile. So another antidepressant is mirtazapine. Mirtazapine has a side effect of sedation, but which is maybe desirable in depressive patients who are having insomnia. And the patient can have the increased appetite and weight gain, and it can be used especially in patients with underweight patients who have the loss of appetite and weight loss. And trazodone also have the side effects of sedation, so we can use in patients with depression and having insomnia. And it has the serious side effects, rare but serious side effect is priapism, and the patient may have postural hypotension because of its alpha blockage effect. Another major antidepressant group is tricyclic antidepressant, so which group includes amitriptyline, nortriptyline, imipramine, desipramine, clomipramine, doxepin, or imazepine. So tricyclic antidepressant works by inhibiting the serotonin and norepinephrine uptake. And it can be used for major depressive disorder as well as other conditions like peripheral neuropathy and OCD, especially for clomipramine. So the adverse effects of tricyclic antidepressants can be memorized as the 3C, which are serious and as conversion, coma, and cardiotoxicity, because the tricyclic antidepressant have the effect of sodium channel inhibition, so it can result in arrhythmia. And especially in elderly, it can cause confusion and hallucinations because of its anticholinergic side effects. And in case of TCA overdose, the treatment is sodium bicarb. Another second-line antidepressant medication group is MUI, which is a monoamine oxidase inhibitor, which includes the tranine-cypromine, phenazine, isocarboxylate, selegiline. Selegiline is a selective MUB inhibitor. Because our body have two types of monoamine oxidase, MUA and MUB. So selegiline selectively inhibits the MUB, and others are non-selective monoamine oxidase inhibitors. So by inhibiting the monoamine oxidase enzyme, the drugs can increase the level of amine neurotransmitters, which are norepinephrine, serotonin, and dopamine. So which are the control neurotransmitters for our mood. So monoamine oxidase inhibitors are especially effective in patients with atypical depression, and for selegiline, we typically use it for Parkinson's disease. And normally we don't use MUI inhibitor for as a first line for depression because it has a serious side effects, which is a hypertensive crisis. We also call it cheese reaction because when a patient ingested MUI together with diaramine containing food such as cottage cheese and old wine, and the patient have the life-threatening hypertensive crisis. And another serious complication is serotonin syndrome, especially one prescribing the other serotonergic medications like SSRI, TCA, St. John's wort, meperidine, dextromethorphan, and linezolid together with the MUI inhibitor. So we must avoid prescribing those serotonergic medications together to avoid serotonin syndrome. And after stopping the MUI, we must wait at least 2 weeks before starting other serotonergic drugs or stopping the dietary restrictions as a washout period. So conversely, if we want to start MUI, we must stop other serotonergic medications for at least 2 weeks. But for some medications have the longer duration of action. For example, fluoxetine. So fluoxetine needs minimum washout period for at least 5 to 6 weeks. So when we prescribe the antidepressant medications, the improvement may be observed as early as the first 1 to 2 weeks, but the patients can have some improvement during the initial weeks, but the full benefit at a given dose may not be achieved until 4 to 8 weeks. So for individuals who do not respond or who do not improve at their first 2 to 4 weeks mark, and then the dose should be optimized during this time. And even with the optimal dose, the patient is not responding, and this is their first antidepressant trial and failed, and the patient is having their intolerable side effects, and there is no response, for example, less than 25% improvement to the initial antidepressant, and the patient can wait for a response because their depression is not that severe, or the patient have the preference to switch to another antidepressant because of one of the side effects or something, and then we can consider switching to another antidepressant medications. When we switch the another antidepressant medications, we can switch in the same class, for example, from one SSRI to another SSRI, or in a different class, like from SSRI to SNRI or bupropion. And we can also give the augmentation treatment when the patient is partially responding to the initial antidepressant but not fully, or the initial antidepressant is well tolerated but the action is not fully achieved, or the patients have tried 2 or more antidepressant trials but with poor response, or the patient is having the specific residual symptoms or side effects to the initial antidepressant but that can be targeted, or the patient has less time to wait for a response with the initial antidepressant because of the severity or the functional impairment, then we can add another augmentation therapy. So as I mentioned earlier, psychopharmacology combined with the psychotherapy offer the more advantage over either modality alone. And the other augmentation strategies with the modest evidence base are like adding another non-MAOI antidepressants, generally from a different class. So for example, the patient is having taking the sertraline and the response is not fully achieved, only partially achieved, then we can add SNRI. And the other medications that we can add on are lithium and tyrosine, or the second generation antipsychotics, usually Guideline and aripiprazole. So now that we move on to treatment-resistant depression. So if we have tried the antidepressants, various antidepressants, and we have been tried but the patient is not responding, then we can choose to undergo for the patient ECT, electroconvulsive therapy, which is found to be the most effective form of therapy for patients with treatment-resistant symptoms. And ECT is a pretty safe procedure, but we need to find the potential indications for caution to use an ECT technique or anesthesia, such as a recent myocardial infarction, cardiac arrhythmia, or intracranial space occupations. And the ECT may have the cardiovascular side effects, but which can be managed by optimizing the blood pressure control prior to ECT and administering the antihypertensive medications. So arrhythmia can occur, but it's usually transient and can be managed with the usual antiarrhythmic therapies. The most common side effects of the ECT is the confusion, which can last 30 to 60 minutes after the treatment, and retrograde amnesia can also occur, but it typically resolves. And ECT is usually administered 2 to 3 times per week, and acute course of ECT typically consists of 6 to 12 treatments until the symptoms are remitted or clearly reach a plateau. And other options to consider, but with less supporting evidence, are transcranial magnetic stimulation, TMS, and vagus nerve stimulation, VNS. And intravenous ketamine is also considered for treatment-resistant depression, but new results studies show that it is inferior to ECT. But still, ketamine is a good option in treatment-resistant depression, especially the patients are declining the ECT. And how long do we give the antidepressant medications for patients? So usually the guideline recommend the patient should be remain on antidepressant medications for 6 to 9 months after they have achieved the remission. And if the patients are at high risk of recurrence or the severe depression, then the treatment should be extended to up to 2 years or more after achieving remission. And the psychotherapy should be continued along with the pharmacological therapies. So when do we discontinue the antidepressant medications? So usually for stable patients, we can consider discontinuation, but how and when to discontinue the treatment has not been systematically studied yet, and it depends on the risk of the recurrence and the severity and frequency of the past depressive episodes, and the persistence of the depressive symptoms after remission or concurring the disorders or the patient preference. In general, the psychotherapy has a longer lasting treatment effect and carries a low risk of relapse following discontinuation compared to psychopharmacology. So patients should be advised not to discontinue the medications before stressful events such as holidays or weddings or etc. And if the pharmacology is discontinued, then we should taper the medications over at least several weeks, because some medications such as SSRI and SNRI, especially for antidepressant with the short half-life, example paroxetine and venlafaxine, that the patient can have their the SSRI, the medication discontinuation syndrome, in which the patient may experience the flu-like symptoms such as headache, fever and chills, and body aches and nausea and lightheadedness, which can be very distressing. So after discontinuing the treatment, we should inform the patient about the potential for relapse and a plan for resuming treatment if the symptoms return. And the risk of relapse is said to be the highest in the first 2 months following discontinuation of treatment. So we should monitor the patient systematically and at regular intervals. So in this lecture, we have discussed about the diagnostic criteria from DSM-5 for the depressive disorders, and we have covered the management of the depression with psychotherapy and psychopharmacology, and how to start the medication, how to continue, and how to discontinue the treatment, and as well as how to switch and how to augment the medications. Okay, so thank you very much and see you in the class.